So, hi everybody. We'll continue the study of the kidney cases. Let me open the screen, the central screen as well. So, this is a case where you see many inflammatory cells. Can you identify which cells are there? Are they? Which cells consist the majority between this infiltrate, in this inflammatory infiltrates? Which cells predominate? Neutrophils or mononuclear cells? Mononuclear cells. So this is a chronic inflammation. I want you to pay some attention to the terms. If we say chronic interstitial nephritis, that means the presence of the chronic inflammatory exudate in the connective tissue, which normally is very little in the kidney, but without dilation of the pilocalyceal system. Because if we have chronic inflammatory cells and dilation of the pilocalyceal system, this is called chronic pyelonephritis. So there are two terms describing the presence of a mononuclear infiltrate in the interstitial disease of the kidney. Always remember that the term chronic pyelonephritis refers to some sort of dilation, either due to obstruction, due to a calculus, as we've discussed in our previous lesson, or due to reflux, a problem. Remember what we said for neglected prostate hyperplasia, that causes reflux of the urine and dilation, and in that case of both ureters, of both renal pelvises, and potentially it can destroy both kidneys. Fortunately, it's not so common. So let's have a look here. You see that the renal function is affected because the creatinine clearance is very low. So the fact that the scars in chronic pyelonephritis tend to appear in the renal poles has to do with the diminished strength of this area to endure the increase of pressure within the renal pelvis. So if you have an obstruction, for example, in one kidney there is a tumor, let's suppose in the retroperitoneum, and strangles the ureter, then we have some sort of obstruction, so we have dilation of the renal pelvis, and if this reaches chronicity, scars appear, preferably at the poles. Yes. It has to do with the structure of the renal papillae there. The renal papillae are either simple or complex. The ones that are located in the poles cannot endure the increase in the renal pelvis pressure of the urine, so sclerosis comes first in the poles. So this is chronic inflammation, either chronic nephritis or chronic pyelonephritis, which always has to do, apart from scarring, to some degree of dilation. So, and most commonly happens after recurrent episodes of infections. And the whole procedure reaches chronicity. And which patients are vulnerable to have common urinary infections? Which patients? Women. Women, because the urethra is not long enough, so the microbes can go easier in the urinary tract, yes, and women are not patients. So I asked, which patients? Diabetic patients who are very vulnerable to infections. Yep. Yeah.
I'm a bit confused. Chronic nephritis is due to infections as well, but
no, it can be immune regulated. For example, if you have a rejection of a kidney, T cells gather there.
Okay.
This is a nephritis, but it has nothing to do with pyelonephritis.
Yes.
The inflammatory infiltrate is mononuclear, but this is an immune reaction, a rejection of a graft.
In a viral infection, we would expect the nephritis.
Theoretically, yes, but I'm not so sure how common they are, so that they cause chronicity, because viruses, as we already know, have no neutrophils, they have nothing to do, and they have mononuclear infiltrates. However, I'm not sure that they affect the urinary system so commonly.
So the most common is pyelonephritis.
Yes, the most common is pyelonephritis. For example, interstitial nephritis could be due to an allergy to an antibiotic. In this case, some eosinophils should be present as well. And I remind you that eosinophils are polymorph, but they have nothing to do with acute inflammation. They are present in either allergy or in other chronic inflammations. Sometimes parasitic infections, sometimes not. The presence of eosinophils among the cells of an inflammatory infiltrate implies chronicity of the infiltrate. So, next. Here we have a problem. Which part anatomic of the kidney is this being involved by the action of this stressful stimulus? It's where the pyramids, which form where the collecting ducts are, looks at the calyces and the renal pelvis. This is an anatomic area which normally does not take so much blood, because renal arteries are final arteries. They do not anastomose. So how does this area takes blood? You remember, it's the renal artery. It enters the hilum of the kidney. Then we have the interlobar arteries. Then when they reach the base of the pyramids, that means the junction between the cortex and the medulla, they become arcuate arteries, and then they enter into the cortex as interlobular arteries. These are which the efferent arterioles bring blood to the glomeruli. The blood is filtered through the glomerular basement membrane and becomes urine, and then we have the afferent arteriole, and this is responsible for all the blood supply of the urinary tubules of all the structures of the kidney, because there is no anastomosing vessels. So that area normally is the last one, because it's down there in the medulla. So it commonly becomes hypoxic, mainly in diabetic patients, and we have necrotic papillitis. However, this papillary necrosis we study in this case is not due to diabetes, it's due to, let's have a look, analgesics, aspirin and phenacetine use. Let's have a look. One necrotic papule was shown in the urine, and you see that the patient saw a passing 0.5 centimeter tissue fragment in her urine. It was quite big enough because it's the whole necrotic papilla that was excreted in the urine. So why did it become necrotic? It became necrotic due to the toxic use of analgesics. And let's see other data showing us that the kidney function was influenced. Can you please comment? How do we understand that there was a problem in the kidney of these patients? Which other markers show that? What do you think? Have a look at the history and you tell me. Take into account what we discussed the day before yesterday. What else? What do you see? To show that the kidney has a problem. Yes, please.
The
The urea nitrogen levels, yes, and remember that we should also take into account the creatinine levels, which are somehow more specific in the serum to reflect the function of the kidney. And I see that the hemoglobin level is low. What does this have to do now? Why is the hemoglobin level low? Is it a chronic condition? Because if we have chronicity, one feature of chronic renal insufficiency is it affects the hematocrit and the quantity of red blood cells and the hemoglobin. Why? Why, if the kidney does not function well, we have a reduce in the patient's hematocrit? We take the presences one by one because it's necessary, because one comes and signs for everybody. I had a note, I wrote a note, please sign only for yourself. However, we were told that we should do it this way. Because I told you, you come here to communicate with me and get a practical grip of medicine. You cannot learn medicine by reading and studying paragraphs in textbooks. That's what I try to do here. That's why we talk. So, I'm not a police officer and try to find who is present, who is absent. You should all want to do this. Not because I say it. I do not want you to do what I say. You must understand it yourselves and do it from your own. I said, you will decide that. It's not because I say that. No, you must think that I'm studying medicine. Medicine is a practical profession. So I cannot spend 6 years of my studies studying paragraphs from textbooks. You'll get the degree. Yes, okay. But what will be the practical utility of this degree? That's why I'm here. So I think of that. That's why we talk freely, like partners, like colleagues. But it's not something I want to impose to you. You have to think it yourself and decide for yourselves. So, okay, then what did we say? Yes, why is in chronic renal insufficiency patients, the hematocrit is low and hemoglobin? Yes?
Because the kidneys produce erythropoietin.
Yes, it's a reduction in the production of erythropoietin. Yes, that's right. Let's see, is this the case here? Let's look at the answer. So we said analgesic. Yes, we found it. Reduced erythropoietin levels. And of course, if we have aspirin, if a patient takes aspirin, we always say that he must eat something first and then take the medication because it causes bleeding through the gut. Aspirin. Yes, please?
Why would we have this ischemia in diabetics? Because you said we find it in
Yes.
diabetics as well. Why?
In this case, I presume it's direct toxicity of the medication. And possibly it may cause some bleeding, so we can see that it's rather brown, and brown color when it's in formalin denotes hemorrhage. But in other cases, such as in diabetic patients, it's a matter of arteriolosclerosis that affects the arterioles of diabetic patients. The mechanism may be different. Here, that we have analgesic abuse, it looks to me that it's directly toxic, a toxic effect probably of the drug. But in other cases, such as diabetic patients, there is no toxic factor, but the lesion of the arterioles, which in many, many diabetic patients and hypertensive patients, they have the nephrosclerosis. That means the iodine gathers in their wall and somehow occludes the blood supply. So think, which is the area which is most vulnerable in hypoxia? The one down the papillae. close to the renal pelvis. We said why? It does not take enough blood easily. So it is mainly affected. And this is a severe complication, mainly when we have acute pyelonephritis. What is acute pyelonephritis? Acute pyelonephritis is a urinary infection that causes pus formation. So think that microenvironment of the papillae being filled with all free radicals coming from the neutrophils, the microbes themselves, and it becomes hypoxic very easily and necrotic. So that was the necrotic papillitis. Here is very interesting because this is the most common cause of acute renal failure. How is this defined? How is acute renal failure is defined? There's no urine. The quantity of urine diminishes in less than 100 millimeters per day. What is this called? This so much severe oliguria. This is called acute renal failure. The most common cause of acute renal failure is the one that is described in this history. So what do we have? It's a middle-aged man, and he has a history of, what's that polysubstance? What's that? What is this a toxic agent? I think in some cases of this condition, we have direct cytotoxicity to the proximal tubules, because the proximal tubules have many microvilli, and they take what leaves the glomerulus. It's the first tubules that reabsorb what passes in the urine. So if there is a toxic factor, because there are some toxic factors that you take, what you put as an antifreezing substance, and it's, of course, it's toxic when you drink that, and you drink it because it acts like a drug. I'm not sure what it is because I've never drank one, but I don't know. Yes, you know what it is. They use it for anti-freezing, and some people drink it because they make them feel somehow. I don't know. I cannot tell you how they feel, fortunately, because if I try to drink that at my age, I probably won't be here to tell you what I felt. I'll be in another condition somewhere else. But young people do that, and it is very toxic. So what does it do? What does it do? It destroys the epithelial cells of the proximal tubules. This destruction is acute tubular necrosis or acute tubular damage. Do you remember from theory what type of cells are they made of? Are they made of stable cells? Are they made, I mean, the epithelial cells of the proximal renal tubules, which are most commonly affected by a toxic agent? You remember that these are cells that are stable cells, not permanent, like the myocardial fibers, etc. They have a stem cell component. That means they can be renewed after a proper stimulus. They do not renew by themselves like covering epithelia. They need a stimulus to be regenerated. But this takes time, and till that the epithelial cells reappear, the patient has no urine. So it's very important to treat him in according to the levels of his electrolytes in the blood. Because which electrolyte, if you you have no urine, which electrolyte may increase in the serum, and this will be very dangerous for the function of the heart. It may cause a very severe arrhythmia, and also it may cause a pause in the heart movements. Yes, please. Is it K? The K? That's right. So you see here that hyperkalemia, okay, which is very dangerous. So, and this led the patients to emergent hemodialysis because there was no other way that the level of potassium is kalium, that is, that the level of potassium is again returns to normal. So he had an emergent hemodialysis. You know the hemodialysis. It's they make a fistula and they take the blood, filter it because the kidneys do not function, and then it goes back to the patient. So hypokalemia was achieved and all the parameters normalized, and you see that this is something that has become, that has given, by the time normality was achieved in the area. And there are two types of acute tubules necrosis. One is due to toxic factors, such as the one we described here, and the other is due to not enough blood supply. If the tubules are not properly supplied with oxygen, with blood, they can have acute tubular damage. So we must find what caused this hypoxia and treat it accordingly. So that was the main cause of acute renal tubular necrosis. There are two different patterns of damage having to do with what the factor, the etiopathogenetic factor is, and you can see them in these graphs. This is the histology. Yes, tell me.
You said that the most common cause of acute renal failure is this.
Yes, acute tubular necrosis. Yes, this is the most common, that the patient does not have urine.
But
It stops.
Not reversible.
Not immediately reversible. If you have the patient stable, and in some cases you can take his blood and make the filters that the kidneys cannot do, it resolves. They regenerate.
The cells.
The cells regenerate because they are stable cells. It takes some time, but always keep in mind that the electrolytes should be within normal limits because you may lose the patient. Yes, please? There? Yes, of course, it's the main cause, yes, because all these toxins circulating in the blood may have a direct influence in the epithelium of the urinary tubules. Yeah.
So it's the toxins, not the hypotension in the...
Yes, theoretically, there are two mechanisms. One is direct toxic in a case of sepsemia, and the other is not enough blood supply. I think, to my mind, in sepsemia is a toxic factor that causes the destruction of the epithelial cells. So you see how they look like? They have become exfoliated. They are somehow flattened. The epithelial cells lining the tubules, they are somehow thin. They seem to be rugged. And it's very interesting that, of course, we have damage, and there are the cells of acute inflammation, the polymorphs, the neutrophils. One would expect that he could find them. It's not so the case. Of course, there are a few. Why? Because some cells have been destroyed, so neutrophils come to the microenvironment of the damaged epithelial cells. Yes, please?
What is oliguria?
Oliguria is a very diminished amount of urine that the patient leaves. To say that it is acute renal failure it should be less than 100 ml per day. Too little, 100 ml. This is oliguria. And if there is no urine at all, no urine, in Greek this is anuria. I'm not sure, total absence. No urine at all. Oliguria is what I told you. But this is the limit so that acute renal failure is defined. Oliguria could be other values, however, diminished. Taking into account and what amount of water the patient takes, or if he has the intravenous supply of fluids. So what was I saying? This is how the affected epithelial cells look. And however, the neutrophils are not many. Why aren't they many? There is no factor, there is no bacterium. Because if we had many, many neutrophils and we had all these cylinders of white blood cells, that would be infection. So there may be some neutrophils, but in no way are they comparable to the neutrophils that predominate when we have a urine infection. So from a histological point of view, this image is not consistent with a purulent factor, a microbe, but it is also something that destroys the epithelial cells. That means there are no neutrophil infiltrates in the lumen of the tubules. There may be some, because it's a distraction, but not many, not many. And this is how you can make the differential diagnosis. Here is another cause that oliguria developed. He had a crash injury to his lower extremities, a motor accident, for example, and you see that the dipstick test in his urine was positive for blood, but there were no red blood cells, according to the microscopy. Why was this false positive finding with the dipstick? There was another substance that had the dipstick be positive, but it wasn't hemoglobin. What was it? What was it? If you have a crushing of muscles, what may be so increased and be excreted through the urine, what can this be? Myoglobin. Okay? So, myoglobin is also toxic to renal tubular epithelium. So you see that all globins, hemoglobin, myoglobin, turn the blood block of the dipstick positive. But when myoglobulin is responsible, there are no red blood cells, of course, in the urine analysis. Look here. Yes, what happened? No, what's that? No. So, have a look at the surface of this kidney. It is very, very granular because these small granules correspond to very, very small infarcts. And in later stages, the size of both kidneys is diminished, and this is called nephrosclerosis. In our previous cases, the problem was in the interstitial tissue and the tubules. That was the part of the kidney parenchyma that was primarily affected. In this case, the disease starts from the arterioles, not the tubulointerstitial compartment, the arterioles of the kidney, not the intracapillary, the extraglomerular capillaries and small arterioles. So, how are these affected? They are there are two very, very common diseases which are potential killers of the kidney. And these diseases are diabetes mellitus and hypertension. How do they damage the kidney? They bring hyaline in the walls of the small arteries of the kidney parenchyma, the arterioles, and they become so thickened that the other elements are not properly supplied with blood. And which are the other elements? The other elements are the glomeruli. So, not enough blood reaches the glomeruli, so they become ischemic and they react by fibrosis. And we have fibrosis of glomeruli. Glomeruli become fibrosed secondarily because the main damage was in the arterioles, the extraglomerular vascular component. So, glomeruli become fibrosed. There is no afferent arteriole. So, what happens? All the renal parenchyma, that means the tubules, there is not enough blood supply. However, this reduction in the blood supply of the tubules is not acute. So it's not acute tubular necrosis as we previously saw. It's more chronically, it takes more time that the tubules are not properly perfused with blood. So they become, yes?
Fibrotic.
That's what happens to the glomeruli that are not properly, that have no blood supply. If a tissue does not receive proper blood supply, if it's acute, it's necrosis. If it is not acute, but it is on an ischemia on a chronic base, that there is some blood, atrophic. So, in this case, the renal tubules become atrophic, secondarily again. So, there is quite a challenge when we have all these parts of the nephron to see which is primarily affected. Is it the glomeruli? It's a glomerular disease. Is it the tubulointerstitial component? This is nephritis, either interstitial nephritis or pyelonephritis, acute or chronic. Or is it the arterioles of the interstitial component? Then we have nephrosclerosis. But in late stages of renal disease, since all these components interact with each other, it's not always possible to see where the disease started. If we have an end stage kidney disease, it's not possible to see. You see, fibrotic glomeruli. Did the disease start from there? You don't know. You see atrophic tubules and fibrosis in the interstitial compartment. Was that the primary lesion? You see thickened vessels. Is that the primary lesion? Why could not this be the primary lesion, the thickened vessels? And so you say that it's not nephrosclerosis. Because, as we have discussed, if there is a disease that starts from the interstitial component, think the interstitial nephritis we saw. Either pyelonephritis with dilation or interstitial nephritis. What does the permanent inflammatory infiltrate of mononuclear cells, chronic inflammation, secrete? It secretes factors that lead to fibrosis. So, this affects the interstitial compartment, but do you remember what is also affected by the permanent presence of a chronic inflammatory infiltrate? What is also affected secondarily? Think. We said that when we had our lessons of inflammation. It affects the wall of the vessels. So in this, it becomes thickened. This is obstructive endarteritis. It has nothing to do with diabetes or hypertension. So it's not nephrosclerosis, but the damage of the blood vessels is secondary to what happens in the interstitial compartment. That's why I tell you, we divide the diseases of the kidney in three main parts. Okay, we take the neoplasm as another, which are disease starting from the tubules and the interstitial compartment, disease starting from the vessels, the main lesion, because as they proceed, they all look the same, and we cannot say. Yes?
You said in the hypertension we have hyaline deposition.
Hyaline deposition in small arteries.
Why is it hyaline, not collagen? Because
That's what's happened. Collagen is what happens in the tissue. Collagen cannot be deposited in an anatomic structure. The only place where collagen is deposited is the interstitial tissue, and this happens there. However, it does not affect the wall of the vessels. We cannot have collagen deposition within the wall. There is another substance that comes there, and we see it in histology. Of course, you may ask me, why? Where was this formed, and we see it on the blood vessels? I'll tell you, I'm just a pathologist. I don't know biochemistry and all this. You have a special interest in biochemistry. You look it up and tell me no.
In larger arteries, though?
No, it's not larger. No, the small ones,
yes,
the arterioles.
In the large arteries that have smooth muscle, we have collagen deposition in remodeling.
Of course, yes, but that's a case when we have the intima destruction, and then there is a repairing process with macrophage. Yes, but in this case, we have inflammatory cells in the vessel. So it's logical that collagen is deposited. Collagen is deposited where we have inflammatory cells. In this case of nephrosclerosis, there is no inflammation. We have the primary damage on the walls of small arteries. Okay?
The third category is glomerular.
Yes. Glomerular, which will take us another lesson on Friday. Hopefully, we'll finish that on Friday. But let's see what we can see next for today. You see the other, what's the kidney down there? The one that is up is destroyed by nephrosclerosis, okay, due to hypertension or diabetes. What's the other one down that is so hemorrhagic and necrotic? This is the transplant that the patient received, and if you see it in this, and it's all hemorrhagic necrosis, what happened to the transplant? And you see it like this. It was rejected. So this is the rejected transplant, the down image, and the other one is the nephrosclerotic kidney due to either hypertension or diabetes. And I would like to stress the relationship between hypertension and the kidney. If I have idiopathic hypertension, the kidney is affected and I have nephrosclerosis. But also, any disease that affects the kidneys themselves, and so it somehow changes the amount of the urine and the components within the urine, make the juxtaglomerular apparatus wake up, and it secretes renin, and this becomes a cause of hypertension. So when we have a patient with hypertension, we must discriminate. Is it idiopathic hypertension, which potentially affects the arterioles of the interstitial compartment and causes nephrosclerosis? Or is it secondary hypertension due to a disease that has affected the kidneys? Yes, want to ask something?
No, just thinking.
Thinking, yes. I'll try to make it as simple, more simple. I think I cannot make it more simple than this. Yes?
In both cases, we have the same result, though, even if it's idiopathic or even if it's...
It becomes worse. It becomes worse. Because if hypertension is established, we have all the consequences. Left ventricular hypertrophy. what we said.
No, talking for the kidney only.
Yes.
Do we still have the same effect? Do we have nephrosclerosis?
Yes, if hypertension develops, it can affect the arterioles of the kidney. Either idiopathic, as most hypertensive patients are idiopathic hypertension. However, if you have a hypertensive patient, you must check the kidney's function, because it could be secondary hypertension. So, next. Heparin, what does this have to do? Heparin, this is interesting. So this patient received heparin, and this caused a reduction in the platelet count. You see how the reduced platelets are, and he had hematuria, increased urea nitrogen, and creatinine. So we have discussed the arteriolosclerosis, which has nothing to do to atherosclerosis. This is no atheromatic disease. However, you see that something interesting, that in a small percentage of patients receiving heparin, autoantibodies can develop and damage the endothelial cells. And this has to do with a prothrombotic state, and this is heparin-induced thrombocytopenia. Wow, what we see from clinical medicine. Didn't know that. Anyway, here we have a long-standing hypertension, and you see that both kidneys are affected in this examination. This is the renal blood flow scan. And you see how we measure. I won't insist on that because this is, you'll learn that in internal medicine, how the creatinine clearance level is calculated. Yes. So, a small introduction to glomerular diseases of the kidney. Diseases that start from a glomeruli. The terms first. When a glomerulopathy affects less than 50% of the glomeruli in the specimen, in the biopsy, the renal biopsy, and less than half is involved, affected, we use the term focal. When more than 50% of involved glomeruli are evident, we use the term diffuse. Focal, less than 50%. Diffuse, more than 50% of the glomeruli examined. When in the affected glomeruli, less than 50% of them is involved by pathology, we use the term segmental. Segmental. That means we have the abnormal glomerulus, and within the abnormal glomerulus, less than 50% of it is damaged. So this is a segmental damage. When in the affected glomeruli, more than 50% is affected, we use the term global damage. So we have global, yes, global damage throughout the glomerulus. So we have the terms focal and diffuse, segmental and global to describe the glomerular lesions. When we study glomerular diseases, we have morphology, which has to do with hematoxylin eosin, pus stain, which highlights the collagen 4 constituents of the renal, of the glomerular, that means basement membranes, and the Bowman capsule around the glomerulus. We have silver stain, which highlights mainly the same things as pus, but it stains black. Pus stains like this, purple. What's magenta? What's this color? Magenta. And also we have trichrome Mason stain. Why? Because with trichrome Mason stain, we study if there is any Mason, trichrome staining. What does it stain? Fibrous tissue. If there is any fibrosis. Because if something is stained by Mason, trichrome staining is fibrotic tissue. If it stains red, with trichrome Mason, it's necrosis. So we have, let's say, that there is a lesion that we detect from histochemistry, and it's green to blue, light blue. So it's fibrosis. What do we say then? Is it in all glomeruli more than 50%? This is diffuse. Is it in some glomeruli less than 50%? It's focal. In the affected glomeruli, is the fibrosis in more than 50%? This is global. Is it in less than 50%? It's segmental. The same with necrosis. We see necrosis. Is it, how many glomeruli are necrotic? Less than 50% focal. More than 50% of them diffuse. And the same within the affected glomeruli, segmental necrosis. Segmental necrosis. Diffuse necrosis is not a term frequently used. Next, we use immunofluorescence. Why? Because we want to define whether the glomerulopathy is due to immune complexes. So, what is the sign that we have in immunofluorescence? If it is granular, if the pattern of immunofluorescence is granular, we have immune complex mediated glomerular injury. And we use the same terms. To define a glomerulopathy to be of immune complex etiology, we must have granular staining and diffuse and global. This is how we know that it is an immune complex mediated glomerulopathy. We have a positive granular sign in immunofluorescence that is in all examined glomeruli, and throughout them, that means diffuse and global. This is the specific sign of immune complex mediated glomerulopathy. And then immunofluorescence may be negative and we have no sign, or it may be linear. This is a specific type of immunofluorescent positivity which is consistent with anti-GBM, anti-glomerular basement membrane glomerulonephritis. We'll see that next time. And the last one is electron microscopy, because electron microscopy permits us to study the foot processes of the podocytes, because what's the glomerulus? It's the capillary lumen where blood comes. This is the basement membrane, which is next to the mesangium, the supportive network of the glomerulus, and we have the epithelial cell on the outer surface of the glomerular basement membrane with the podocytes, primary and secondary. So, what do we see in the electron microscope? If there are immune deposits, where are they? Subepithelial, that means down the podocyte, or subendothelial. What is subendothelial? Where we have the endothelial in the capillary close to the inner part of the basement membrane. It has to do with immune complex deposition. What else do we see in electron microscopy? The food processes, are they well-shaped or are they flattened? Because in this case, we do not have immune complex pathogenesis, we have some sort of podocytopathy. That's just an introduction. We'll continue on Friday. We have a lesson 12 to 1. I'll try to make it as concise as possible, because if I want to have it fully developed, then we'll lose Black Friday offers. Yes.